My name is Lucia D'Ambrosio. I'm a senior lecturer in global public health at the University of Aberdeen and also have a position at the University of Witwatersrand in Johannesburg. I work in global public health, which means working all around the world. I've been very privileged in my career to work in a lot of low and middle income countries, and for the last 13 years I've been working in rural South Africa. I'm a social scientist, so although I hang around with a lot of doctors and nurses and medical researchers, I take a social view of health. Cost of living, cost of smoking. We were interested in how people were coping with prolonged economic shocks in the form of the current cost of living crisis and what smoking looked like within that. The overall picture of Scotland, of course, is a success story with tobacco regulation. Smoking rates overall are really low. But taking a social view of that, when we look inside those overall smoking rates, there are huge disparities. So we wanted to understand smoking as a social problem and focus specifically in low-income communities. So that's where that kind of cost of living, cost of smoking name came from. And we sought to recruit, I think, 12 participants, adult smokers or people who had some kind of lived experience with smoking, the financial hardship of the current cost of living crisis we're in, or had had their lives affected by smoking in some way. And we recruited community partners, a name we came to agree with the participants in our research study, and I think reflect the participatory kind of approach that we took. So we wanted to get that insider view, that community intelligence. So we sought to work with 12 community partners, and we connected with those people through Turning Point Scotland, who, as I said, are embedded in rural communities and have trusted relationships with people accessing alcohol and drug services. We then went through a structured process of trying to surface with people their lived experience of tobacco, the cost of living crisis, and what tobacco use was like in that context. The evidence that we have developed through this process suggests that this may have some benefit to understand realities in underserved communities, how to address those realities, but critically perhaps how to do so on an ongoing basis, not as a one-off diagnostic, going beyond that and moving towards something more relational between service users and providers. So when we worked with community partners and really mapped out who are the players in your smoking behaviour, it absolutely started with the individual and individual willpower. But we quickly saw how, and a quote from one of our participants, the individual is a grain of sand compared to the influence of statutory services and support services to make different choices, and those wider kind of industry influences and commercial partners, and particularly at the time that we did this research around e-cigarettes. Similarly, when we problematized collectively smoking and understood from people their experiences and motivations and drivers for smoking in the cost of living crisis, it very clearly came back to us that the root causes of smoking were stress-based. And it's not rocket science when you think about it for a moment. There's increased stress from the cost of living crisis, and community partners reported increased availability of smoking products, namely and particularly e-cigarettes, which are cheaper, more affordable, more socially acceptable. But our community partners helped us understand the reality of e-cigarettes, and it was overwhelmingly negative. We got many different angles on this reality. not only from people's lived experience. We used a technique called photo voice, where we worked with community partners to collect, analyse, select and caption visual evidence. And we were really shocked at how much of our results focused on e-cigarettes. We were interested in tobacco at the outset, and almost were going down, not looking to steer our communities, but almost going down the route of talking of tobacco, but wanted to have an authentic process. So, you know, had due space for communities to have their voice. And yeah, this reality of e-cigarettes was something we kept coming back to, as well as the fundamental root causes of smoking, e-cigarettes and otherwise, being stress-based. We had one dedicated session on what poverty means, and what kind of language is appropriate to talk about hardship and multi-dimensional hardship and poverty and so on. It was a fascinating session. Our community partners didn't feel great about the term poverty. We looked up dictionary definitions and agreed that it was an adequate phrase to describe people's lives. Nevertheless, people felt that term was disempowering, stigmatizing, and just not useful. And it was a real instruction that our language around poverty it's not good enough, and it's not connecting with, and in a worst case scenario, may be excluding people from. Just being real about the reality of these situations and what it means for our health and well-being. So there's a lot of policy support and recognition for social and community-based approaches to health, which is incredible. Where the challenge is implementing those and doing that in an effective way over time and sustainably. What we've learned and what we got out of this was about relationships and trust and people and the value of that, and probably some insights into how easy that is to overlook. These fundamental things, often called the soft side. We talk about the software and the hardware in health systems. And I think the technological, the hard stuff is natural for us to develop and work on. I think what we've learned over the years in South Africa is that the soft stuff, the relational stuff specifically, and specifically the relationship between underserved communities and health services, state and society, for us is where it's at, is the thing to focus on. And over time, we've come to focus on low and no cost solutions to use existing resources smarter to serve the needs of those whose voices are least represented. I think one of the main things we found was the empowerment of community health workers through creating spaces that their value could be recognised in the system by higher level planners and managers. And those spaces were difficult to convene and to have productive and useful discussions in, but nevertheless, with careful management, we found benefit in them, and not just for community health workers. We were able to mobilise communities and develop trust with the health services. We were able to generate completely new data and evidence for higher levels of the system, for planners and managers. And we used those successes to transmit learning upwards to higher sort of strategic policy and planning levels, which is where we're at the moment. We've really been encouraged by the response. NHS Grampian, as I was saying, and particularly with health improvement, they've supported us all the way through. And we think that response reflects the value of the approach. As we were talking about earlier, we've seen this works in very different countries and contexts. We've got some modest evidence this may work and have benefit here, and we've had quite an overwhelmingly positive response from different levels and sections of our health authority. So the natural next step, I think, for me, is further development and testing. what kind of concrete actions could result from this, what can we learn from that, and then crucially to reiterate the process and continually be asking ourselves whose voices are not at the table, always being critical and self-critical about power and things like that, and about authenticity with participation and co-production. As I said, there's so much policy support and recognition for it, and that is great. What is less abundant, and perhaps where we can make a contribution, is technical know-how about how to actualise those policy commitments. And ultimately, and I think working with ASH Scotland, connect community voice to the commercial, political and social drivers of health inequalities. I think through long connections to our health service in Grampian as well, really in the same way, enabled, informed and supported us to attempt trialling the approach from South Africa here in Scotland. So I think what was special and unique about our partnership was the way that we were all very different partners coming to the table, and we all brought something quite unique and worked with our differences to do something interesting. And of course, another critical partner has been Turning Point Scotland, a group who of course have deep expertise, trusted relationships in our rural communities, specifically and for our purposes addressing drug and alcohol problems. So yeah, with ASH Scotland and your scientific and political expertise, with Turning Point Scotland, their community links and community capabilities, with the scientists, of course with the people we worked with as well. So I think one of the main things we got out of this study was a high definition voice from the community on the realities of e-cigarettes. It's a moving target. There's a nascent, emergent evidence base on e-cigarettes. They're used differently, even by different countries in the United Kingdom. The community voice that we surfaced in this project gave an overwhelmingly negative view of e-cigarettes. And to quote from our paper on the study, community participants conveyed the realities of e-cigarettes as widespread availability online and in everyday shops, affordability, social acceptability, fewer restrictions in the home and on transportation, fewer restrictions in smoking duration, widespread dual use, feeling more addicted to nicotine because of e-cigarettes, and anxiety over the long-term health effects. The explicit targeting of children and implications for people who have never smoked were further concerns, as were environmental impacts. Overall, people saw e-cigarettes as replacing one problem with another, and that was something that was quite unanticipated.